Well, I'd like to, first of all, thank the organizers for the opportunity to talk and for providing the introduction, the visual introduction for what my talk will be about. Because indeed, it's about Michael Jackson with that beautiful silhouette, the excellent dancer he was, and what he should have known before he went into his, about anesthesia pharmacodynamics and about anesthesia monitoring. So, I'll give you a little bit about the timeline, clinical timeline first. There are two, the cast of characters here is two. One is Michael Jackson, and the other is the physician who was hired to be his personal physician to keep him in shape for the upcoming tour that he was going to go to England and be in residence for several months. Jackson had a long, many-year complaint about chronic insomnia. When Conrad Murray came on the scene, Michael Jackson already knew about propofol that he called milk. He knew you needed lidocaine to go with it. He knew what doses he liked. Now, you have to remember the story we're hearing here is coming from Conrad Murray. So you can take anything that is said here with serious self-interest. For 6 weeks prior to Michael Jackson's death, Murray stayed with him at least 6 days a week, giving him propofol essentially every night to treat quote-unquote insomnia. On the fateful night, after a long practice session, he came home, he was dehydrated, and Conrad Murray started an IV in him. By the way, his arms were no longer usable for IVs, and the IV went in the lower extremity, and tried a bunch of benzodiazepines, diazepam, lorazepam, some midazolam also. That didn't work to put him to sleep. So finally, Conrad Murray said, okay, you can have the propofol. He gave some propofol, and then something happened. We'll get back to that in a minute. Michael Jackson was taken to UCLA, declared dead there. No one could figure out why he died all of a sudden. But the coroner figured it out after taking blood samples that he had died of acute propofol intoxication with some contributory benzodiazepine effect. Well, what happened in more detail? Again, the story here is coming from Conrad Murray's as his personal physician. And by the way, if you want to read all the juicy details, this is detailed at length in Wikipedia, so you can go day-by-day blow of the trial if you're interested in. But we're focusing in on that particular night. Murray gave Jackson this propofol in a bedroom in this mansion they were renting. There was an oximeter, yes, it had no alarm, it had no plethysmograph, but there was an over-the-counter, so to speak, oximeter that he was using. There was no other resuscitation equipment. It turns out, he gave a continuous drip of propofol. There was, what the coroner found is not what Conrad Murray said was going on. But there was evidence of empty bags, empty IV bags, and many empty and part empty vials of propofol, including from that night, 100 milligram bottle empty. So when Murray gave him, he said 25 milligrams of propofol, started the drip a little bit, and watched him. After he was comfortably asleep, after watching him for 10 minutes, Murray said he left the room for 2 minutes, to make a phone call, and when he returned, Jackson was tachycardic, unresponsive, not breathing. It goes downhill from here. Conrad Murray did one-handed CPR on the bed, and then delayed calling 911 for 20 minutes. That's the emergency number in the US, to call for the emergency rescue squad. And he told the emergency medical services he was treating Jackson for dehydration. He didn't mention the propofol at any point until they found the propofol that was there. So the trial, somewhat later, the charge was involuntary manslaughter. What the defense said is that Jackson self-administered the drug. This, of course, didn't hold. I mean, you can dismiss the pharmacodynamics entirely for this, because what the defense proposed is that in the 2 minutes he said he left the room, that Michael Jackson woke up, gave himself more propofol, and died immediately. Okay, that was trial number, I'm sorry, that was defense number 2. Defense number 1 was that he drank it and went to, you can laugh, that he drank it and that's what killed him. There was, that got sort of taken off the table quickly, because there's a lot, you can't get yourself to sleep by drinking it. You won't get it, it doesn't work that way. It can't work that way. So then they want the self-administered. That was, so we're talking here, the pharmacodynamics is that 25 milligrams of propofol is going to provide a surgical blood level inside of 2 minutes, enough to kill him by the time he came back in the room. So this talk is not about pharmacodynamics or pharmacokinetics, it's talking about medical monitoring. Because that's what the issue is here. And that's what the prosecution case was about. Basically, that this physician, Conrad Murray, violated any standards of care, and those actions were gross negligence, and in fact, he was convicted for that. So the issue is monitoring. Now, the story, for those of you who were not around at the time, it was big press every day, all the time. And we had 2 medical experts here. Steve Shaver, who many of you know, and what's written here is like the media summary of what it is. He authored the package insert and argued that these were just simply egregious and unforgivable deviations from standard of care. And he said, yeah, Michael Jackson didn't die because there was some magic effect of the propofol. You don't do chest compressions to treat the side effects of this drug. Michael Jackson died because he stopped breathing. Point number 2 was, this is not an acceptable treatment for insomnia. The defense, not a acceptable treatment for insomnia, and no competent physician would have, or any kind of healthcare professional would have given these drugs with no emergency equipment around whatsoever. And for those of you who know Steve well, he's a very enthusiastic and earnest person. He actually did this he consulted and testified without charging a fee, because he thought that this whole trial and the Michael Jackson case had frightened patients and given anesthesia a bad name, and he basically wanted to do the defense to defend anesthesia as a practice of medicine. This is not anesthesia. On the other side was Paul White, another expert, pharmacokinetics expert, and again, he tried to talk about the rapidly administering the dose and dying immediately from that, but in any case, it still was given, even he had to admit, it was given not it shouldn't be done in a bedroom, and wouldn't be a treatment for insomnia that he would ever support. Now, it was a huge media show. There was some other anesthesia. Do any of you know Barry Friedberg? He was, okay, so, he's another anesthesiologist. He's at the fringes of our profession, but he's very good at getting media attention and also stormed the whole business up. So, now here, so the problem is not pharmacodynamics, the problem is bad medical care, and essentially, to the theme of this meeting, terrible monitoring. What Steve pointed out, he created some very interesting videos to watch on how propofol should be given, and basically listed a whole collection of things of actions that were violations of what he said are the standard of medical care. First, there's the role of Conrad Murray as Michael Jackson's personal physician. No, he wasn't an anesthesiologist. He actually led even his internal medicine boards, labs. He worked as a cardiologist, he'd been trained as a cardiologist, never got board certified in that either. So, but as his personal physician, this is what Conrad Murray should have done if he were providing medical care for his patient. There is no emergency airway equipment, there's no advanced airway equipment, there was no suction, no infusion pump. It was postulated afterwards that what he did was spike one of the vials, cut open an IV bag, and hung it from that to let it drip down. He, as a physician, he failed to maintain a proper doctor-patient relationship. He let Michael Jackson tell him what to do for medical care. He didn't get informed consent for this. I mean, he's given a drug, and he's providing medical care. He didn't document, there was no written evidence of what actually was given. They simply found the coroner went back to the house and found the bags of stuff in the closet and in the drawer. It turns out that Conrad Murray asked Michael Jackson's bodyguard and chef to take all of those things and stuff them in the closet, and that's where they found them. But more importantly, he didn't call for help. And he didn't call immediately. What he said at the trial was he couldn't call for help because he didn't know the zip code of the house. I mean, it's not even believable. He just was clearly not, he was trying to hope this would all go away. And apnea doesn't go away in this particular kind of circumstance. And he failed to disclose to the paramedics and to UCLA when he got to the emergency department, well, when his body got to the emergency department, that Murray had used propofol and didn't tell what he saw in terms of the arrest. He said he came back, he was dead, and he did CPR on the bed because Michael Jackson was too frail to pull to the floor. Okay. I can only paraphrase a lot of it. The reeling part, those were violations in terms of his role as a physician, and now we get into specifically monitoring. There was, the pulse oximeter had no alarm, there was a blood pressure cuff in the closet, there was no cardiogram and no capnography. He did not in any way monitor the mental status of the patient. He said, well, usually when he goes to sleep, he snores. This time he wasn't snoring, so he assumed he was okay. He didn't monitor the breathing, didn't use any of the monitors that he had. So, what do real experts say about anesthesia monitoring? And I went through some of our national organizations, starting with the US, because this is where this event happened. The first thing in the ASA's basic anesthesia monitoring standards is you have to have qualified personnel present. That's the primary monitor. Then you need devices to amplify your senses, and continuous monitoring as with oxygenation, ventilation with some measure of exhaled CO2 and measure of circulation. All the monitoring standards mention temperature, but it's not really relevant to this case particularly at all, but they do all say audible alarms. What about Great Britain? Very similar. Number one is the continuous presence of an appropriately trained and experienced anesthetist. And for sedation, even for sedation, where monitoring devices are supplementing clinical observation, you still need a pulse oximeter, non-invasive blood pressure, cardiogram, and a capnogram with a waveform, which is what that standard asks for, whenever there is loss of or likelihood of loss of normal response to verbal contact. And again, audible alarms with set alarm limits. And being here here on the continent, the monitoring authorities, the European Board of Anesthesiology, and theirs are parallel lists. Again, the determinant of an appropriately trained, experienced anesthesiologist, and specifically for sedation, a pulse oximeter, non-invasive blood pressure, cardiogram, capnography, and audible alarms. This set of monitoring standards points that if you're going to use an infusion device, you should check it before you use it. The one I would also like to quote our esteemed expert, Dr. Hendricks, who looked at comparing the monitoring standards worldwide. This was in the Anesthesia Patient Safety Foundation newsletter, looking across there, that there's a lot of inconsistency across about the strength of the requirements. Are these standards? Are these recommended? Should consider these? But they all have core requirements that every anesthetized patient has to be continuously attended by a qualified anesthesia professional. They all have some requirements for clinical monitoring, here with devices supplementing observation, and alarms need to be turned on and need to be audible. So, some final sort of reflections. And a lot of this on the trial, again, it ends up not being pharmacology and pharmacodynamics, but it is about the adequacy of medical care. Here we had conflicting goals and results. You had the ethical conflict between patient safety and what the celebrity here was demanding. But even if your patient is not a celebrity, the physician is still responsible to make a physician decision no matter what the patient is pressured to do. So there's not a matter of only a celebrity. This is a widespread more issue. And the other professional reflection is that patient monitoring is imperative, and monitoring standards support or encourage us to support patient safety. Finished. So what should Michael Jackson have known? Well, if he would have known something about anesthesia monitoring, it might have saved his life. He clearly, what we had here was a physician who, on a monitoring, we failed. The number one thing on the checklist is the person who was monitoring him did not know what they were doing and was neither trained nor experienced. And we also have to say with the alarms, capnography would have helped with alarms. Pulse oximeter with alarms would have helped. Using an infusion pump instead of having a run empty 100 ml bottle of propofol dripping with what the coroner said looked like there'd been a spike put into the bottle and it had just run in. Anesthesia depth monitoring, and of course, emergency airway equipment, and always some documentation so if you're going to need help, there's known what was happening. Well, thank you for the opportunity. Fortunately, none of us are in this position with Michael Jackson. What a loss.